It's time for Health Futures with Cypress Home Care Solutions, Bob Roth. This is Arizona's only show dedicated to providing you with expert advice on how to live a longer, healthier, and happier life. To learn more, call 602-264-8009. That's 602-264-8009. Now, here's your host, Bob Roth.
Good afternoon. You're listening to Health Futures, Taking Stock in You. I'm your host, Bob Roth, and it must be Friday, and indeed it is. We're coming at you live from the Scottsdale Air Park Studios on Money Radio, 1510 AM, 105.3 FM, and the World Wide Web, moneyradio1510.com. We're coming at you here on Friday, February 18th. And our show is an excellent show, as it always is. Our show is about how our older adult population can live a healthier, happier life. How do we do this? We do this by bringing extraordinary guests to the show, and today is no different. I'm really pleased to have in the studio with me from the Arizona Center for Cancer Care, I've got Dr. Mike Franz Janicek. He is with the Arizona Center for Cancer Care, Virginia G. Piper Cancer Care Network. He is a surgeon, does treatment, and specializes in the area of gynecology. Welcome to the show.
Thank you very much, Bob. I'll preface this by saying I listened to your show last week with my partner, Dr. Steve Skolnick. You guys were smooth. There's no way I'm going to be that smooth, but I love this topic. I talk fast. I talk a lot. So if I'm going overboard, just do a cutthroat sign to me, slow down.
No, I don't think you'll ever go overboard. But, I want to just tee it up by just telling us a little bit about you and your background and your training, and then we'll jump right into the work that you're doing.
Sure. So I'm a gynecologic oncologist. Archie Bunker used to say a groinecologist, and a lot of people don't understand what we do. Everyone knows what an OB or a GYN does, but gynecologic oncology are OB-GYNs who we do our 4 years of residency, and then we do a 3 or 4 year fellowship in gynecologic oncology. And I trained at the University of Miami with Dr. Hervey Everett, who founded the specialty back in 1972. And these are general surgeon-trained docs who wanted to go into female cancer surgery. And we're the only medical specialty that also treats women for gynecologic cancers with chemotherapy. So we're a blend of medical oncologists, those are doctors who do chemotherapy only, and surgeons who do surgery only. So we do both, which makes this job a lot of fun, very fascinating. It's the best profession to go into. I just love this job. And what also I like about it is we're a continuation of OB-GYN. A lot of OB-GYNs deliver women and their babies. They take care of them for life, do their hysterectomy maybe later in life. They have this continuity of care. We don't just operate and then send the patient on to someone else. So many of our patients, unfortunately, we have a lot of cancer patients that don't all survive, but we have many survivors, and it's just a pleasure to follow them over the years. I've been here 23 years. I have some patients that I've had for that long.
Wow.
And it's great to see them grow up. They get to see how I've aged and my beard's turned gray, and it's a lot of fun. So I love this job, and so I'm happy to explain that what we do. It's a rare specialty, and we're very good at what we do because we focus on female cancers. We don't treat all cancers like medical oncologists, but we're very good at what we do because that's all we do.
Well, I'll tell you what, your practice covers the spectrum of different cancers. And when I talk about your practice, I'm talking about the Arizona Center for Cancer Care. And this is a specialty, obviously, that you are quarterbacking and you are working on. I don't know and don't profess to know how much cancer there is in terms of ovarian cancer and cervical cancer. And I know that today, still leading cause of death, number one is hearts and number two is cancer. Can you give us a little, information as to, where things are with ovarian and cervical cancer and how much progress are we making?
Sure. Well, overall, the good news is cancer death rates are declining in this country. We're making a lot of progress. I mean, lung cancer is still the number one killer, and you've got colon up there. Breast is the most common female cancer. So the cancers we deal with aren't necessarily the highest prevalence, but they're among the most deadly. Ovarian cancer is 5 times deadlier than breast cancer, for instance, because you can't catch it early enough. So there's sort of a difference between prevalence. Like prostate cancer is the most common human cancer, for example. Half of all men who die with prostate cancer, not of. So if you do autopsies on all men who die, half of men have prostate cancer at the time. But that's not the big killer. It's
right.
The most prevalent. So, I don't want to get into too much of a rabbit hole between incidence and mortality. But,
sure.
We are what we are. So we're not like way up there in terms of the numbers. But what I'd really like to focus on is even if the number isn't the highest in the nation, there's things we can still do and need to do to lower those numbers. I'd like to talk about vaccinations and the impact on cervical cancer, the great new treatments we have for ovarian cancer, the genetics, how that impacts, because genetics leads to prevention. So we can talk about cancer, death, and treatment, but what's better than treating a cancer and curing it? That's preventing it in the first place.
Exactly. You know, it's interesting. It has touched my family, and I'm going back almost 60 years, where my mother was diagnosed with ovarian cancer, and she had 1 2/3 removed, and she had like 1/3 of an ovary and was able to have 3 children,
Wow.
which is fascinating. I mean, you know, it just goes to show you that you know, it's not the end, and you know, ovarian cancer is something that obviously is serious, but you know, it's prevention that you're talking about, and getting, you know, actually getting exams. Pap smears, I would think, is probably the number one exam that you need to take.
Well, we've evolved beyond that. Pap smears was developed in the 60s and became popular in the 70s, but now with HPV, human papillomavirus testing, the American Cancer Society is actually preferring HPV testing only above the pap smear. So we've evolved to the point where cancer genetics, cancer virology, viral testing, just like we test for COVID, we can do home COVID tests. We're going to reach a point where people could do home HPV tests. You don't have to necessarily, this is the future now, I'm not saying this is what we should be doing now. It's kind of primitive to have to go in and put your legs up and the doctor has to examine you. It's very unpleasant, but we have the ability. We do nose swabs at home, right? And we do COVID testing and send it in. We have the ability and the technology to do that. And that's really more important for the underdeveloped world where they don't have a lot of doctors, because worldwide, cervical cancer is still a big killer. About 600,000 cases a year, about 250,000 deaths per year worldwide. Not so much in this country. There's about 4,000 deaths per year, and about 14,000 women get cervical cancer. But even those are preventable with the vaccine. So I know we're jumping from treatment to screening, but they're all interrelated. And I think the thing I'd like to really get out to the listeners out there is really to embrace genetics more, because the technology of genetics, whether it's ovarian cancer and hereditary cancers, the treatments directed at genetics, or whether it's HPV and the vaccination for HPV, they're all related to genetics. We wouldn't have a vaccine if we didn't understand the HPV genetics. So I'm also, as a disclosure, medical director of our Genetic Risk Assessment Center. That's my side hobby and passion, not just operating on people and giving chemo. Genetics is my real hobby, because I believe that almost all human diseases can be explained by genetics. So when we talk about cancer and disease prevention, it's hard to avoid the topic of genetics.
You know, Dr. Janicek, you talk about genetics and you talked about the correlation, and I know so much has changed, but there is a direct correlation to breast cancer and ovarian cancer, is there not?
There is, in a subset called breast ovarian cancer syndrome. Gilda Radner was, back in our generation, sort of the popular case that everyone, it always takes a celebrity to get cancer to understand that it's something important, right?
Unfortunately.
And Angelina Jolie was widely publicized, and in Time magazine, her mother had breast cancer, but up to her great-grandmother had ovarian cancer. So the two go hand in hand, and they're caused by the mutation in one of several genes, in her case being the BRCA gene. And so having a mutation in that gene can predispose to breast and ovarian, but for men also prostate, also pancreatic. So having an understanding of genetic testing and the ability to test if you're at risk allows one to be proactive. You can take ovaries out. You can do MRIs for breast cancer. There are things you can do to prevent or catch for breast cancer early. And for ovarian cancer, you can remove fallopian tubes or ovaries. There are things you can do with the power and information of genetics. And if you don't test, you don't know, and then you're stuck getting the disease and treating it.
You know, I have a dear friend of mine back from where I grew up in Baltimore whose mother had a twin. They were two very, wonderful ladies and gorgeous women, and one had passed away from breast cancer, and the other one was told to have her breasts and ovaries taken out. Whatever genetic testing was done back 35 years ago, and she refused to have her ovaries taken, and she ended up getting ovarian cancer. So my friend who ended up having babies, her doctor said, when you have your last baby, we're going to do the works, and it was prevention so that she would not have that cancer. So I can't believe we're down one segment. We got a little bit of the WHO taking us out. We got a lot more to talk about, Dr. Janicek, but it's really good to have you here in the studio. We're talking about ovarian cancer, we're talking about cervical cancer, we're talking about gynecology and the work that you are doing. Genetic testing is really fascinating. So for our listeners, stick around. We got 3 more segments. You're listening to Health Futures, Taking Stock in You. I'm Bob Roth, and I've got Dr. Janicek here in the studio. Stick around. We will be right back.
Now back to Health Futures, taking stock in you. If you have questions about your own or your loved one's future health care, call 602-264-8009. Now, here's your host, Cypress Home Care Solutions, Bob Roth.
Welcome back. If you are just tuning in, I've got Dr. Mike Franz Janicek here in the studio with me. He's with the Arizona Center for Cancer Care over there at the Virginia G. Piper Cancer Care Network. If you missed our first segment, please go out to our website at cypresshomecare.com. Click on the media button. Third button down is radio show. So Dr. Janicek is a highly trained gynecological oncologist, and he does far more than that. So, definitely, if you missed our first segment, go up there and learn more about his training and what he has done and what he continues to do here in our community. So I want to really take the second segment and really do a deeper dive into cervical cancer and cervical cancer awareness and prevention and some of the things that we talked about. So I'm going to bounce it back over to you, Dr. Janicek.
Great, thanks. So HPV is one of my favorite topics, human papillomavirus, and its relation to cervical cancer, because I've had a research lab at the University of Miami where we studied immunotherapy of cervical cancer. This is back in the 90s. Today, we have clinical trials now using immunotherapy to treat cervical cancer. So even though I'm not active in the field anymore, some of the early work I was doing really has evolved to the point where it's impactful. And what I love about this topic is that everyone's now an expert on virology and immunology with COVID.
Right.
And we've actually been through that because we understood that HPV causes cervical cancer. It's not the biggest problem in our country in terms of 14,000 women, 4,000 deaths. Worldwide, however, over a quarter of a million women die each year of cervical cancer. So what's really important about cervical cancer, it's preventable, not only through pap smears and screening, but even better now with HPV vaccination. So we all have had the debate about COVID and vaccinations and anti-vaxxers and mandates and all this, but we've been there, done that. In 2006, the FDA approved a vaccine for cervical cancer. Back then, we didn't know quite how effective it would be. Fast forward to today, we find out that it prevents 90% of cancers. So even though it's not a high number, it's low-hanging fruit where we can prevent these cancers with vaccinations. Of course, that triggers the debate back then on a smaller scale. Some people may remember that the vaccinations are recommended for girls and boys starting age 11, maybe as early as age 9, depending on when they become sexually active, because, I must emphasize, human papillomavirus is the most common sexually transmitted disease in this country. 80% of women have it, but many have it and don't know it because it goes dormant. But HPV is extremely prevalent and successful. In fact, every mammal on the planet has some form of papillomavirus. So it's been here way before COVID. It's been around a long time, and we don't talk about it much. But it's not even just about cervical cancer. Men are now getting oral, pharyngeal cancers from the upper airway from oral sex and HPV there. So it's a prevalent problem. It's controllable. And so even though the numbers aren't as high as colon and lung cancers and breast cancers, we understand it so well and it's so preventable that it's a shame to not avail ourselves to the technologies, the treatments, the vaccinations, and the therapies that are available now. So I just want to say, in this country, there's 14 million new HPV infections per year.
Wow.
And so it's out there. And, I have 2 young girls, and I certainly would want them to get the vaccine before they become sexually active. I don't want some guy giving it to them. Of course, men have it too. They just get off easy. The penile cancer is much less common than cervical cancer, but they're shared equally. Highly contagious virus.
It's interesting is, I didn't realize that the HPV vaccine was recommended not only for women, but men as well. And you mentioned about, the fact that men could be carriers of it, but they don't have quite the symptoms. So could you maybe elaborate a little bit more on that and what that may look like?
Well, everyone knows what genital warts are.
Right.
You can get penile warts or women can get warts, and those are the lower risk. But the more dangerous strains of HPV, everyone knows about Omicron, and people understand different
Delta.
strains of Delta, right? There's over 100 different strains, about 80 different genital strains. So we actually understand, we have numbers for them. So, for example, HPV 16-18 are the cancer-causing ones, 6-11 are the wart-causing. So we've got it down where we don't worry so much about warts. They're ugly. They can be treated. It's the 16, 18, and some of the other high-risk types that we can test for and screen for and vaccinate against so that men don't get it and men don't pass it on to their loved ones.
Right. Typically, do people have symptoms that, would set them off to
Not
maybe...
until it's too late.
That's
If
so
you've got
sad.
bleeding and a cervical mass or you haven't had your PAPs, it's too late. So the symptoms are an abnormal pap smear. So we do recommend screening. Screenings change, and women used to get PAPs every year. Now it's evolved to PAPs every 3 years. But if you use the HPV technology and just test for the virus, the American Cancer Society now prefers women get screened for HPV only, not even the PAP, every 5 years, because the screening is so effective. If you don't have HPV today, even if you get it tomorrow, it would take about 5 to 10 years to turn into cancer. So that's why the screening is spaced out. The problem I have with that is women have been so used to seeing their gynecologist every year and getting their PAPs that who's going to remember, was it 3 years ago or 4, or when did I have my last? So I do worry that when the screening becomes so infrequent that it won't become part of the routine anymore.
So is the screening the pap smear, or is there something that's more evolved? Because you talked about it in the first segment about doing some... You get to the point where we get to home testing. We're not there yet. But
we're not there yet. Everyone understands the pap smear. You can do both. A pap smear just looks at cells that look abnormal, and then you can do HPV at the same time you do the pap, and that's called co-testing. But in underdeveloped worlds, or the technology will evolve where, just like the home nasal swab for COVID, women can send in a tampon or swab of the vagina to a test kit, test for the DNA, and find out if you have HPV without going to the doctor's office. Again, I'm not a proponent of that at this point. I'm just explaining. We all understand how you can do a nasal swab at home. We're not that far away from doing this for other cancers. What I would rather do is get some kind of screening than no screening, is my point.
So in the first segment, we talked about genetic testing. This is not genetic testing. This is cancer that is passed on through sexual transmission, right?
But it's genetic. The
is
virus
genetic,
has 8 genes, and they're cancer-causing, and we know exactly how it causes cancer. We know the genes responsible. So it's one of the best and earliest understood models of how genes can cause cancer.
So if a mother has HPV and it's dormant and gives birth to a child, that could be passed on?
Just through the birth canal. So thankfully that's infrequent. Children can swallow and get HPV in their oropharyngeal tract, and maybe genital, but frankly, if a young child has HPV, that's a concern, and it could have been maternally transmitted. But predominantly, we're talking about a disease of sexually active people.
No, listen, you're giving some great information, and certainly I have some family members, as you talk about the HPV vaccine back in 2006 and the late 2010 era, if you would, between 2000 and 2010 era, that refused to get the vaccine. And what would you say as we wind down our second segment, first half? What would you say to those people that are anti-vax and really don't want to do this to their children?
Well, first and foremost, I'm a big believer in freedom and choice. I think that when it comes to child, and you have to decide between 3 and 1 million chance of a bad reaction, and pretty much anything you put in your body, whether it's penicillin or peanuts or whatever, people can have deadly reactions to. So you take 3 in 1 million versus an 80% chance you're going to have this virus in your lifetime, and the peace and comfort of knowing you may get something else, but you're not going to die of cervical cancer. I would, right now, towards those risks. I mean, we get in a car every day and risk dying in a car accident.
Right.
So I think it's sort of an individual choice. I don't believe in mandating or forcing the schools to inject your children, but I think the patients should be educated, not by the government necessarily, but hopefully their doctors, and the pros and cons. And I still believe in choice, but that doesn't mean you don't believe in vaccinations. You can believe in both, believe it or not. Unfortunately, we're so polarized in this country. It's all political, where you're either an anti-vaxxer or you believe in mandates and forcing everyone to do what the government says. And I think there should be a healthy debate in between, and just focus on the science and not the politics.
Right. And certainly, as we talk about young children, and look, my children went and saw their pediatrician up till they were 15, 16 years old. And I mean, this is about the time and the age that you're looking to get someone vaccinated, or maybe just before. it really starts with the primary care physician, really having that discussion and really having that thoughtful discussion about what vaccines should I have.
Exactly.
Well, it's hard to believe it, Dr. Janicek. It goes really fast here. So we got a little Coldplay taking us out here in the second segment and first half. And, I really want to jump into in the second half. I want to talk about genetics because it is the key. And you did share with us it's kind of your side hustle and you're entrenched in that, and it's not your everyday work, but you do that on the side. And I think it's really important for people to understand what their genetics are so they can really understand what they're predisposed to. There's that 21andMe and others that are out there, and I don't know where you stand on that, but we can talk about that in the second half as well. You're listening to Health Futures, Taking Stock in You. I'm your host, Bob Roth. I got Dr. Franz Janicek here in the studio. He's with the Arizona Center for Cancer Care, Virginia G. Piper Cancer Care Network. We're down one half. We'll be right back.
Now back to Health Futures, taking stock in you. If you have questions about your own or your loved one's future health care, call 602-264-8009. Now, here's your host, Cypress Home Care Solutions, Bob Roth.
Welcome back. You're listening to Health Futures, taking stock in you. And if you're just tuning in, we're in our second half here. I have got Dr. Franz Janicek. He is from the Arizona Center for Cancer Care, part of the Virginia G. Piper Cancer Care Network. I want to give them a plug. If you want to go visit their website, go out to arizonaccc.com or give the phone number 480-270-5309 if you want to learn more about them and if you want to learn more about what Dr. Janicek is talking about here in the studio. So it's hard to believe we're down one half and we got so much more to cover. And, we talked about genetics, and I really want to do a deeper dive into genetics and really the importance to genetics in your family history. We talked a little bit about that in the first segment, but I want to do a deeper dive. I mean, we've learned so much about genetics and how they really dictate our outcomes, or at least the path of where we go in terms of our health. And Dr. Janicek, if you could take us through some of the work that you're doing. I know you talked about it. You're still very involved in it, although the gynecological work that you're doing for cancer is, your primary gig, if you would. Can you really talk to us a little bit about how much family history and genetics really play into things?
Well, they're actually all related. So just to back up a little bit, I am the medical director of our Genetic Risk Assessment Center. So I work with 3 board-certified genetic counselors. We review over 2,000 cases a year. So there's that side gig, as you put it, but it's also directly related to my daily work. So Just let's take ovarian. Well, let me backtrack a little bit. I'm going to geek out here for a second.
That's all right.
Let's all understand genetics. So what we're talking about is genes, and there's a lot of phobia about genes and paranoia. I just want to say the genetics, this makes us who we are. It's the blueprint. It's the instructions. And so believe it or not, it's hard to believe that there's 3 billion letters to the genetic alphabet that make us what we are. 3 billion.
Wow.
So the Bible has 3 million words. So if you stacked 1,000 Bibles on top of each other, just visualize that all those letters are the genetic code. And a single misspelling in our genetic code can cause cancer. It's fascinating. And you can find that and test for that. So just to help people understand the scale of things, there's 22,000 genes in our body. That's not that many, and about 300 of them are cancer causing. So we can actually wrap our hands, we're starting to wrap our heads and hands around the cancer problem, but we still have a lot of work to do. But it's now gotten to the point where it's not just, I've got a bad family history, a lot of cancers. We're at the point now where we can be proactive, we can test, and not to fast forward too much, but it actually now impacts cancer treatments. Cancer treatments are now evolving to the point where they're targeted therapy based on your genetic alterations. Back in my day, in the early days, we'd just give a toxic chemo, platinum, and it'll kill a bunch of cells. What type of cancer doesn't matter, and it didn't matter about the genetics. Now we're refining things to the point where the genetics matters for treatment. But for this segment, I do want to back up and say the family history is important. Using ovarian cancer as an example, 1 in 4 ovarian cancers is caused by hereditary cancer mutation, 1 in 4.
Wow.
So it is standard of care now for every oncologist who treats an ovarian cancer patient to order genetic testing for the inherited type as well as the tumor. So you may not be born with a mutation, but you may have developed, for instance, the BRCA mutation and get ovarian or breast cancer, or you may be born with it, and both are important. So they're related and they're both important. So germline is hereditary and somatic is the tumor testing. So we do both. So it is now at the point where every woman with breast cancer, the American Society of Breast Surgeons recommends genetic testing, period. Regardless of family history, you may not know who your real father was, or your family history may not be right, or you may have lost a lot of people. So my point is, we're not even at the point now where we over-focus on the family history. Pretty much for all ovarian cancers, genetic testing, all breast cancers, genetic testing, all metastatic prostate cancer, all pancreatic cancers. Over the past few years, the guidelines have evolved to the point where all major cancers require genetic testing. Why? Because information is so powerful for treatment. And the side benefit, of course, is for your family. So if you were unlucky enough to get breast or ovarian or one of these other cancers, and it was caused by a defect in one of these 22,000 genes in your body.
But you only said about 300 of them are cancer causing, right?
Right, or one of those 300 cancer.
One of those 300.
It doesn't matter.
Yeah,
it just takes one,
Yeah,
and it just takes one spelling of one letter in the genetic alphabet, and you can get cancer. So we don't have time to go into how that works.
Sure.
The power is we can test for DNA very powerfully, and if you have this alteration and you have cancer, it affects your treatment. And for your loved ones, if they inherit it, they can do proactive things such as risk reduction interventions, whether it's screening, imaging, risk reduction surgery. There's all kinds of options. So tremendously powerful. So the message I want to get out there is genetics is a good thing. There's rare cases where genetic information is bad. And I think there's people out there that says, oh, I won't eat genetically modified corn because it's going to mutate me. And I'm going I think there's a lot of misunderstanding on what that really means, because you eat corn and you digest it and your DNA and proteins get broken up in a million little pieces. And genetically modified foods don't do anything to you, but yet it's that phobia. I don't want to get genetic testing. Maybe the government's got my DNA,
right.
Or there's a lot of, some of it may be legitimate, how that information's handled, because the genetics is so powerful. I can tell you, for instance, whether you have dry or wet earwax, your genetics. If you gave me a sample of your spit,
wow,
I could send it to 23andMe, and they can run a Prometheus analysis that costs $15, and I could get the report, and without digging my finger in your ear, I could tell you if you have. I know it's a silly example, but I'm saying it's genetics can tell us about traits, how we metabolize drugs, whether we're likely to get cancer, Alzheimer's disease. I can go on and on and on. So medicine is evolving to the point where genetics tells us so much, and we're scrambling to just discover more and more information. We're so far behind, but there's so much ahead of us. So there'll be a day where our children, grandchildren, before they ever see a doctor, will get a full genomic profile, get a full report about their whole risk profile. The problem right now is we don't understand what to do with all this information we're getting. Doctors don't like to not understand things. We don't like to explain, right. But that's where we are now. We have a golden age ahead of us where nothing's stopping us from understanding ourselves better in terms of what makes us go wrong. And genetics is the root of that.
It's interesting. Information is power. And you talk about how we could probably, do this with children, but I know that there's been talk about doing stuff like this in utero too. I mean, it's science fiction, I know. Yeah, we're not there yet, but
No, it's not science fiction. In fact, we're at that point where women who do in vitro fertilization and they have a fertilized embryo in the test tube and they have a genetic disease, they have the power, and I don't want to get into the moral or ethics of this, but they have the power whether to implant an embryo that has a known genetic defect in it. I mean, it gets into the sensitivities about genetic cleansing and genetic purity. We have the technology called CRISPR now where you can go in and genetically fix that single misspelling that we talked about.
That's so fascinating.
And we have the ability to eradicate certain disease. The Chinese actually cured some beta thalassemias in embryos and then destroyed them because it was unethical to actually. But, you say it's science fiction. It's not. It's here today. What's holding us back is we're scared to go into things we don't know how to control.
Right.
And the technology's there, but we're all being cautious, scientists, ethicists, policymakers, government. But who's to say the North Koreans won't do? I mean, who regulates them? So the technology is there where we can fix mutations. The Chinese are already screening all their Olympic athletes for genetics that gives them better muscle mass, better fast twitch muscles for runners, the slow twitch for weightlifters. I mean, we were there. It's just scary stuff. It's kind of fun to talk about. It's kind of scary, but if we don't talk about it, someone's going to do it, and if we don't get ahead of ourselves, I know we're digressing here from cancer.
No, but I love this stuff, though. I mean, I just think we've come so far, and we still have yet so far to go. But what we can do to eradicate diseases from our society by being able to do some of this work. I am familiar with CRISPR. I mean, that technology is just so fascinating. It really is.
Just for the audience, I mean, you have the ability to insert a gene segment that replaces the bad DNA and just fixes the part and then grow that cell. You know, it's just, you can't take a whole body and change every cell, but you can go back to the stem cells.
Right.
And we're actually using that to treat cancers now. In T cells, you can genetically engineer T cells to fight certain cancers. And so the technology is just giving us unlimited possibilities almost in terms of what we can do in medicine moving forward, beyond the traditional chemo, radiation, and surgery.
And even through genetic testing, I mean, when we look at our family history, family tree, and if we are in that position where we need to do genetic testing, it really helps maybe for other people to get closure, to really understand why their grandfather may have passed away at an early age, or maybe, you know, their grandmother had Alzheimer's and dementia because there's that gene that exists. That genetic testing is what really shares that information. So information is power. It's not something I would, you know, think that you're not recommending everyone to go out there and run out and get genetic testing, but certainly it's something that you might want to talk to your primary care physician about. And certainly if you have a diagnosis, then as you said, those diagnoses being prostate cancer, being ovarian cancer, cervical cancer, I know I'm missing one, pancreatic cancer, that you go in for genetic testing.
Exactly.
Well, you know, time does fly. We're down 3 segments. I want to really jump into our last and 4th segment. I want to talk about the importance of genetic testing in treating your cancer. It is fascinating. I could talk all day about, you know, what could be done in the future and what future generations are going to be looking like. They say that kids that are born today are going to live to an average age of 105. It's just fascinating to me. It really is. You're listening to Health Futures, Taking Stock in You. I'm Bob Roth, your host. I've got Dr. Janicek here in the studio. He is with the Arizona Center for Cancer Care. And again, I want to give out the website is arizonaccc.com or 480-270-5309. We'll be right back.
Now back to Health Futures, taking stock in you. If you have questions about your own or your loved one's future health care, call 602-264-8009. Now, here's your host, Cypress Home Care Solutions, Bob Roth.
Welcome back. You're listening to Health Futures, Taking Stock in You. And if you're just tuning in, we're in our 4th segment. I'm your host, Bob Roth, and I've got Dr. Franz Janicek here in the studio. He is with the Arizona Center for Cancer Care. His specialty is gynecological oncology, and if you missed the first 3 segments, we covered a lot of stuff. I would like you to go up to our website, go to cypresshomecare.com, click on the media button, 3rd button down is radio show. So in our 3rd segment, Dr. Janicek, we were talking about genetics and the importance of genetics to your family, but I want to really spend this time about genetics and how it is being used for your treatment. You know, you talked about it in our 3rd and in our 2nd segment about, you know, where we've come in technology and the fact that we can be laser focused rather than taking this shotgun approach. And I'm thinking that's where you're going with genetic testing so that we can get right to the heart of the issue, if you would. So if you would pick up on that and really talk about what genetic testing means as it relates to treatments.
Right. So we covered the power of genetics to predict whether you're at risk for getting cancer, if you inherited something. So let's forget that for a minute. Let's say, well, I'm not going to worry about it. I just don't want to know. I'm just going to live my life. But let's say you get cancer and you're in trouble now. Let's say you have ovarian cancer or any of these other cancers. We're at the point now where we don't just treat cancers based on what type it is. We actually focus more on the genetics. So let's go back to our example. So you didn't test, you were able to be proactive, unfortunately, and you end up with ovarian cancer. And I've already mentioned that 1 in 4 are caused by hereditary mutation. About half of all cancers have a genetic mutation that is treatable with a new drug called PARP inhibitors, poly-ADP ribose polymerase inhibitors, if you want to get geeky about it. And why that's so important is you now have half of ovarian cancers that have a target that is extremely potent and powerful. So while the genetic mutation may have caused your cancer, it's also its Achilles heel. we can now, there's a bizarre thing I tell patients where, you have ovarian cancer and we're going to do genetic testing, and I kind of hope you have the mutation because that means you're going to have a better prognosis, survival, and treatment. I hope it's not in your family and that you don't pass it on, but for you today with the cancer, this stuff is important and powerful. And so what that means is, let's say you have a mutation in the BRCA gene. You have an inability to repair your DNA in a certain way, and the tumor cells are very susceptible to this drug called PARP inhibitor, which is a pill. And when you're done with chemotherapy and you have a BRCA mutation and you take these pills after you're done with treatment, we have patients that half the patients with advanced stage disease have not even recurred in 3 years. They're still surviving. They haven't even recurred, whereas those that don't take these pills, half of them have already recurred within 16 months. So this is a game changer where we're changing progression-free survival by years, not months, years. And so there were many years where someone would publish a paper where some drug gives you 3-month better progression-free survival, and we get sort of excited, and the FDA would approve a $10,000 a month drug. We're talking years now, and maybe, I want to say this cautiously, some cures, because 13% of women on these PARP inhibitors have been on them 6 or 7 years in maintenance, when before, this is for recurrent disease, when before, once ovarian cancer recurs, it's going to recur again and again and again until you die. Now, for the first time in my career, we have women with recurrent cancer who have a chance.
Wow.
If not at a cure, at least at living longer, free of disease. And these are pills to take. Now, not that they don't have side effects, but my point is, in my whole career, when we were frustrated and it was depressing for a while, we could just give 2 drugs, Taxol, Carbo for everything. These PARP inhibitors, for those patients who have this genetic alteration, which is about half, only about half of that half is inherited, the other half is acquired. The point being, if you have that alteration, if you have that genetic information, the FDA has now, over the past few years, FDA approved these expensive drugs because they work and they're game changers. So that's just one example of how genetics allows you to have a drastically improved prognosis. The other example would be understanding genetics with immunotherapy, and kind of getting back to the whole HPV thing. We talked about how you can test for HPV, you can screen for it, you can vaccinate it, but what about treatment? Last year, the FDA approved a immune checkpoint inhibitor for frontline treatment of cervical cancer that's recurred. And the reason that works so well is because the HPV infection is a foreign infection. So our immune system is pretty good at recognizing foreign infections. The problem is cancer cells kind of outsmart us. They outnumber us. They're not intelligent, but by sheer numbers, they mutate. They figure out ways to outsmart us passively through Darwin's theory of evolution. There's so many. There's 1 billion cancer cells per gram of tissue. Wow. It just takes one of those to figure out. So let's say you're part of the immune system. You're a natural killer cell or T cell, and I'm an HPV-infected tumor cell. How do you get rid of me? Well, you're going to come at me and you're going to choke me to death. That's how you do this. That's how you take me out. But what if I'm the cancer cell and you've got a little button on you that has a little off switch, your self-destruct button? I'm going to just press that button and you're going to go away. And that's how cancers evade the immune system. They have an ability to switch the immune system off. These new immune drugs block that. They prevent the cancer cell from switching off your immune system. Wow. So they essentially unleash your immune system that was ready to do its job, but the cancer cells were just pressing the off button all the time. Now with these new drugs, your immune system can do its job, and these are another game changer. So for cervical cancer with HPV that express PD-L1 is the name of the protein, the programmed death ligand, the off switch. The ones that block that allow cervical cancer to have much more impressive responses than they did before. Endometrial cancer, colon cancer, a lot of those have these what we call deficiencies in DNA repair that cause the tumors to mutate so badly that the immune system says, hey, this doesn't belong to me. I want to get rid of it. And these immune checkpoint inhibitors allow the drug to work and they allow the immune system to do its job by blocking the cancer from turning it off. And I've oversimplified it, but this is the first time in oncology where one drug is approved for any cancer that has this feature. It's called high tumor mutational burden or mismatch repair deficiency. So we no longer say, well, it's a colon cancer, or it's a pancreatic, or it's ovarian, or it's a cervical. If you have this genetic and molecular feature, you are eligible for this drug, regardless of what you name the cancer. So what I'm saying is, oncology has evolved to the point where we no longer give cancer names, they're generic, traditional names. We now talk about them in terms of oh, is this patient mismatch repair deficient, or is she homologous recombination deficient? We have all these new jargon to describe to each other whether the patient has a special feature, where it's not. One patient with ovarian cancer looks the same under the microscope, will be totally different genetically, and we totally treat them differently, and they have a different prognosis. So that's where we've made the progress. Because in the past, it'd say, oh, you have ovarian cancer, you open up the cookbook, and this is what you get. Medicine has evolved, oncology has evolved to the point where our targeted therapy now says, but what kind of ovarian, and does it have this alteration? What kind of breast, what kind of colon? And so that's where the game changers have taken place. And these drugs aren't just like making, like I said, 3 or 4 month benefit. We're now approaching where it's making years of a difference.
Fascinating. It really is. But if I understand you correctly, you actually are, that success is really based on the amount of mutations, right? If it's not mutated, what happens then?
We're back to square one. So if you're unfortunate and you have this cancer and there's no targets, no alterations, well, you just use the standard treatments. So this isn't a game changer for every single patient, but my point is we shouldn't treat every patient the same and just say, well, this is how we used to do it. You ask the question, you do the genetics, whether it's inherited or the tumor genetics, both are important, like I said. The more you know about your enemy, the better you're going to fight it. And so it's not going to be positive for everyone, but it's going to be positive 10, 15, 25% of the time, 50% in time for ovarian cancer. That's enough to then impact the low-hanging fruit, so to speak, the ones that we can make the biggest difference on. So I'm not out here to say, oh, we're treating all cancers and we're all succeeding on every cancer. But
right.
For many of them, we're making a big enough change where we're starting to see cancer incidence and cancer mortalities going down. And so there's a lot of good news ahead.
I love hearing where you're at, and I love how you use the descriptor, the on-off button. That was great for me, and I know it was for our listeners. We got a little less than a minute, and I really would like you, Dr. Janicek, to ask, is there a question I haven't asked? Is there something you want to leave as a final message?
Sure. I think I was trying to get the point across how genetics is important, but how sort of going online, and there is direct-to-consumer genetic testing available. Ask your healthcare provider, and if they're not sure, if they're not geeks like I am in genetics, that's okay. We can't all be experts at everything, but ask to get referred to someone who has. We have genetic counselors, we have genetic referrals. Go online, take some responsibility, and go after this yourself. Don't assume your average doctor is going to be into this and do all the thinking for you. Be proactive. Know your genes. The commercials. Know what's in your wallet.
Yep.
I would say know what's in your genes.
Oh, I love that. I really do. And if you want to learn more about Dr. Janicek or the Arizona Center for Cancer Care, you want to go to arizonaccc.com or call the number 480-270-5309. Dr. Janicek, I've learned so much here today, and I can't believe this was your first time you did radio.
Yeah, I was really nervous, and you're kind of rough on me, but I survived. Thank you.
You did fantastic. Make it a great day. Have a great weekend. We'll be back next Friday.
There's no place like home. You've been listening to Bob Roth's Health Futures. If you have questions about your own or your loved one's future health care, call Cypress Home Care Solutions at 602-264-8009. That's 602-264-8009. Or visit cypresshomecare.com. Be sure to join Health Futures with Bob Roth every Friday at noon, right here on Money Radio 1510 and 105.3 FM.